Hello, everyone. Providing an overview of the things that we had gone over in week 5 as we're getting ready to prepare for our first exam in RCP 210. That test will be 50 questions, all multiple choice questions. They may be some multiple style questions where you've got answer choices 1, 2, 3, and 4, and then it could be 1 and 2, or A is 1 and 2, B is 1, 2, 3, and so on and so on. You all have seen those. You're ready for those. You're prepared for those. There will be some calculations on the exam, so 50 questions probably give you about an hour and a half to take said exam. Then I'll get it scored back to you, and then we'll go ahead and move on with the next items on the agenda. So I know we went over this uh, on Tuesday, so try not to be overly verbose, but kind of hit the highlights of what's going on to review what we've got for the day to day. So the difference between hypoxemia and hypoxemia is low levels of oxygen in the blood. Hypoxia is low levels of oxygen at the tissues. So as far as arterial blood gas interpretation is concerned, we do have mild, moderate, and severe hypoxemia. We also have normal. So in 80 to 100 is normal, 60 to 79 would be considered mild, while 40 to 59 is considered moderate hypoxemia, and anything less than 40 would be considered severe hypoxemia. I have seen in some texts that they would utilize 60 to 80, 40 to 60, and then less than 40. The downside to that is if you were to land on something that was 80, a PaO2 that's 80 millimeters of mercury or a PaO2 that's 60 millimeters of mercury, if you're going by some of those values that you might see, it might be difficult to determine whether that's mild versus moderate or what have you. So it is best to utilize those normal ranges. From 80 to 100 is normal. 60 to 79 millimeters of mercury is mild hypoxemia. 40 to 59 is moderate hypoxemia. And then anything less than 40 millimeters of mercury are going to be considered severe hypoxemia. Moving forward, we've got different types of hypoxia. So remember, hypoxia is down at the level of the tissues. So you can have hypoxemic hypoxia. There's not as much oxygen in the blood, so therefore there's not as much oxygen to get to the tissues. So the tissues are going to be starved of that as well. Then you've got anemic hypoxia, so the ability of the red blood cell to carry oxygen, which can be problematic. So along with that can come into account your abnormal hemoglobins and things of that nature. You can also have circulatory hypoxia, which should intuitively make sense. We provided some pretty good examples of that during testing. And then there's also cyanide poisoning. Cyanide poisoning, that may come back again on your TMC when you go to take that. So cyanide poisoning can lead to histotoxic hypoxia. Uh, Meaning that the cells are unable to utilize that. So when you start to talk about the ability of the tissues to utilize oxygen and so forth, and go back and review the difference between aerobic metabolism versus anaerobic metabolism. If you've ever been in the hospital setting and you've heard them say, "I'd like to get an arterial blood gas, but also check a lactic acid level or a lactate level with that." Lactic acid tends to be the byproduct when you have uh, uh, the tissue's not able to utilize the oxygen as well, so your lactic acid would tend to go up. So we do have various different things that we can look at for assessing oxygenation, starting off with some of the more simple items in the upper left-hand corner, and then it kind of gets into some more of your calculated values where you've got to have a little bit more advanced hemodynamic monitoring and so forth to be able to see some of those. And you all have utilized these when you did your cardiopulmonary case study when we had cardiopulmonary anatomy and physiology back in the spring. Uh, so those are good calculations to review as well. And then some of those formulas are listed for you in that blue box there. So you can have too much oxygen. Oxygen can be hazardous to an individual's health in higher concentrations. You have to remember that the room air that you and I breathe in has a oxygen concentration of about 21% or a percentage of about 21% in it. You got roughly 78 to 79% nitrogen and a very small percentage of other trace gases. So anything above 21% for all intents and purposes is hyperoxygenation for the patient. So it's providing a higher FiO2 for those. And we also talked about the difference between FiO2 and FiO2, the fraction of inspired oxygen versus the fraction of delivered oxygen. And we also reviewed our low flow and our high flow systems. Your high flow system can meet or exceed the patient's peak inspiratory flow demand, as opposed to where a low flow system cannot do that. And you have to take into account when you're breathing in oxygen through a nasal cannula. So let's say we're receiving supplemental oxygen via nasal cannula. As you're breathing in that 2 liters per minute nasal cannula, you breathe that in through your nose. Well, your inspiratory flow the inspiratory flow that you're going to generate when you breathe in is likely greater than 2 liters per minute. So there's going to be some room air that gets entrained. So it's 100% oxygen at 2 liters coming through that nasal cannula, but you also breathe in some of the room air. So when you mix 100% oxygen with 21%, which is in the room air that you and I breathe, that's going to make it less than 100%. So if you all remember back from RCP 110 when you went over to your introduction to oxygen therapy, uh, under normal circumstances, tidal volume and so forth, and respiratory rate, nasal cannula, you can estimate that uh, running a nasal cannula at 1 liter per minute is essentially the equivalent to about a FiO2 of 24%. And then you know that for every liter up above that, you add 4% to it. So 2 liters would be 28%, 3 liters, 32%, and so on, up until you get to about 6 liters. And that is with your basic low flow nasal cannula. If you're utilizing your air entrainment ratios like we had talked about in the past, and we did some examples of these on the board, and we also provide that. I'm going to do the first year group's going to be in on that in the next week or two, so I'm going to provide a little bit more detailed lecture on that in the next week or two. That'll be available should you need to revisit any of that. And then we know that 100% oxygen for an extended amount of time can lead to oxygen toxicity, can also lead to absorptive atelectasis, which can be problematic because it's going to throw off your ventilation and perfusion matching, can cause some asynchrony, can cause issues with oxygenation, and just really begin to stress the body. So oxygen is good, however, you can have too much oxygen. And then remember, we said as we're creeping up on our FiO2. So if you've got someone that is experiencing a lower SpO2, so they've got signs and symptoms of hypoxemia, but it's responsive to oxygen therapy, you can just go up on their FiO2 to an extent. However, if you find that you're having to get up to about 50 to 60% FiO2, and they're intubated, mechanically ventilated, at that point, you would probably also want to begin creeping up on your PEEP, your positive end expiratory pressure, start giving them more PEEP. And then vice versa. If you're starting to wean your FiO2 once you get down to 60 and moving less than 60, you want to try to back off on that extended amount of PEEP that you have in the chest as well. So those, just you have to pay attention to what's written in those questions. So when we talk about how high should we go up with our FiO2, how low should we go with our FiO2, there is the desired FiO2 calculation. So you would take your desired PaO2, what do you want the PaO2 to be? Multiply that by what your known FiO2 is, and you'll do that as a percentage, and then divide that by the known PaO2, and that number will come out to give you an approximate or a calculated value for which you should turn your FiO2 to on the ventilator. We did talk about the hazards associated with, or the hazards and complications associated with that. That formula that you've got the classic shunt equation or the pulmonary shunt calculation. So the QSQT, where you take the CCO2 and subtract from that the content of arterial oxygen, then you've got the CCO2 and subtract from that the mixed venous oxygen content, and you work that out, and that is how you could calculate your overall degree of shunt. Airway, mean airway pressure, we've talked about that. Mean airway pressure should fairly, for the most part, be synonymous with better oxygenation. So if you can improve your mean airway pressure, you should hopefully be able to improve your overall oxygenation for the patient. So we can do that with conventional ventilation. We have that with high frequency oscillation ventilation, and we have some different modes of ventilation that we can employ too. You see inverse ratio ventilation listed there. You've got airway pressure release ventilation. So we've talked about that. You can see the striped area underneath the curve there. That's all indicative of what our mean airway pressure would be. And remember, more mean airway pressure tends to equate to better oxygenation. So if you're in pressure control ventilation, you could do a little bit more pressure if you like. You could do more inspiratory time. That should hopefully help improve your oxygen. You could employ an inspiratory hold. However, you just got to make sure that the patient's not going to air trap or anything like that. And then if you're in volume control ventilation, pretty much the same things. You could maybe give a little bit more volume if the patient's able to do that. Adjust your I and E times, and you do that essentially by manipulating your flow, because as you change your flow, that's going to change your I time. Uh, which is going to have an impact on your IDE ratio. So do keep that in mind. We did also mention about atelectasis, how that can bring about a situation where you have shunt. Shunt is going to be where you've got perfusion and no ventilation as opposed to dead space. That's where you have ventilation without perfusion. So we did talk about those goals of PEEP and CPAP therapy. Do make sure that you can remember those. We did talk about standalone CPAP versus endotracheal CPAP, and in the week 4, we also had talked about or showed you some loops to look at where you're able to basically be able to determine the difference in your overall work of breathing for those patients. So we do look at our low PEEP, which is essentially just to establish our functional residual capacity. So remember, we talked about way back in week 1 the normal lung volumes and capacities. So those lung capacities are made up of two or more any lung volumes. Your FRC specifically is made up of the expiratory reserve volume and your residual volume. So ultimately, a low amount of PEEP just helps to help maintain that FRC. If we get into therapeutic PEEP, we're trying to counter refractory hypoxemia. Remember, refractory hypoxemia is when you have someone whose PaO2 is lower than what it should be, and you go up on the FiO2, you would hope or expect the result to be more oxygen should equate to a better SpO2 or a better PaO2 for that patient. But in some cases where they may have shunt or situation like we had talked about in the past with the atelectasis, may be areas, significant areas of the lung where there's more perfusion than there is ventilation. So uh, those areas may not respond to greater oxygen levels because the oxygen is actually not able to come into contact with that alveolar capillary membrane in that particular region. So what you'll do is you'll add a little bit more positive end expiratory pressure or add some therapeutic PEEP to that. So what that's going to do, it helps. We said that PEEP's going to help establish or maintain your FRC. In this case, if we've got areas that have become atelectatic or they're underventilated, hope that can help recruit some of those unventilated alveoli in those areas and improve your ventilation perfusion matching and so forth. And then we look at optimum PEEP, which is part of what's going to be on your exam too, where we start to look at at what point in when we're adding extra pressure to the chest, extra positive end, extra pressure to the chest, are we getting more bang for our buck with that? Are we getting the best oxygenation for the patient with the least hemodynamic compromise or cardiovascular compromise for that patient? So those would be examples of those cardiopulmonary side effects where you start to get hemodynamic or cardiovascular compromise with that, such as a low blood pressure, cardiac tamponade, because as you go up on PEEP, that is pressure that you're going to be holding within the chest. And the chest is intact, so that pressure doesn't escape the chest. It can go in and it can begin to have a tamponade effect on the heart. We reviewed items such as compliance, airway resistance. We talked about hypoxemia, hypoxia. So those are definitely things that we want to make sure that we are attentive to as we continue to move forward. And then here you can see different degrees of the effects of PEEP, how we're able to and what you see there is the PaO2, the functional residual capacity, the static compliance, and the overall shunt. What we want to try to avoid is where you see on the far right graph is where we begin to start to have overall reduction in compliance, and we begin to have a reduction in our cardiac output. That could potentially indicate that there is um, negative cardiopulmonary side effects associated with that. So what we looked at, PEEP studies, you may hear the terminology PEEP study where we're trying to find optimum PEEP. Example here, you've got 5-minute increments in which they decide to go up on that, and you can pay attention to areas like your static compliance throughout. We can also look at what our PF ratio may be. Additionally, you can look at your alveolar to arterial gradient. You can also look at the CO2 to end tidal CO2 gradient as well, and pay attention to your cardiac output. You might, if blood pressure is listed, make sure that you're paying attention to blood pressure as well. But ultimately, you look at all those values and you see those that trend in the right direction or if they're trending in the wrong direction, and then you start to get an overall idea of which level of PEEP is actually the most advantageous, and at which point you should basically stop going up on the PEEP because above that it's going to be negative for the patient. Assessing your patient, again, you look at breath sounds, ventilator parameters, what anything you would look at with a patient or a patient ventilator assessment. And I always tell everyone, start off with patient appearance. Yes, we've got these ventilators, we've got physiologic monitors that our patients are attached to, but don't forget there is a patient attached to those items. So we don't want to get into a habit of treating a monitor and not treating the patient. So monitors may look well, but the patient might not look well, and vice versa. So make sure that you remember there is a patient attached to those monitors. Uh, the criterion that we talked about through looking at that flow sheet. So some normal values are listed. We did go over these in pretty good detail in class the other day. So make sure that you review those items and basically if the range for it is out of range, have a good appreciation for why it's out of range and what that might mean or be reflective of. So we talked about the CaVO2 difference as well. If that gradient happens to increase, make sure that you review those items that might cause that increased gradient. Make sure that you review the items that might cause a decreased gradient as well. And the same for the next few items that we'll look at. We did talk about pulmonary artery occlusion pressure, pulmonary artery capillary wedge pressure, or PCWP, PAOP, and PAWP. They all mean the same thing. You may see them in different ways. Remember, we talked about with pulmonary vascular pressure monitoring, you're going to put in a pulmonary artery catheter. Well, the TMC may refer to it as a pulmonary artery catheter. You're also here in the hospital referred to as like a Swan-Ganz catheter. Likely your TMC exam is probably not going to refer to it as a Swan-Ganz catheter. They may call it a pulmonary artery catheter, but there's also a decent chance they'll refer to that as a balloon tip flow directed catheter. So if that be the case, we know that you've got a distal port and a proximal port. Off of that distal port, you can get your mixed venous oxygen sample, but also through the distal port, that's where you would look to wedge the balloon in the pulmonary artery so that you can get the pulmonary artery capillary wedge pressure, and then obviously not leave it in the wedge position because that could lead to pulmonary infarction, and that would be not advantageous for our patients. So make sure that we're paying attention to what occurs with those pressures, with the levels of PEEP that are there. You do want to make sure that you have an appreciation for the contraindications for positive end expiratory pressure as well, whether they're relative or absolute. Remember, relative is yes, there are reasons that support why we shouldn't go up on our PEEP or add PEEP in general. But ultimately, the benefits are going to outweigh the risk associated with it, so we'll go ahead and utilize it. If it happens to be a absolute contraindication, then the evidence just says no, you shouldn't do it, and that is the answer. You should not do it because there's really no benefit that's going to happen. It's all harmful to the patient, can make it worse. Uh, and we see that untreated pneumothorax or a tension pneumothorax could be because obviously the extra pressure in the chest could definitely worsen that situation for the patient. We did also talk about the difference between the dependent regions of the lungs versus the non-dependent regions and the role that gravity plays in that. So make sure that you review those concepts. And that's just an example of how those pressures can be transmitted within the lung and of itself. So ultimately, they can only go but so far until they kind of collapse back inward, and then that's where the tamponade can become a bit of an issue. And you also have to look at the impact of not only just lung compliance but chest wall compliance as well. So we've talked about PEEP for issues within the lung. Why are some other reasons why we might utilize PEEP that's not exactly a result of acute lung injury, what have you, but we do have, like we had talked about and given some examples of postoperative atelectasis, congestive heart failure, sleep apnea, and cystic fibrosis for those as well. If you go up on PEEP, you need to have a plan for weaning off of PEEP, and we began to talk about that as well. So once you start to drop, like I said, if you're going up on your FiO2 at about 60%, you need to start adding some PEEP with that. And then if you're able to wean your FiO2, it's okay to start coming down on that on your PEEP at that point as well. And just make sure that you have corrected the underlying cause for whatever it was that caused the individual to need those that additional support via endotracheal mechanical ventilation. We talked about the two different definitions for ARDS. Talked about some strategies, the ARDS NETS protocol that we had mentioned there. Ultimately, you're going with lung protective strategies for those individuals. Uh, the difference in the pathophysiology, you had this also back when you had RCP 115 with pathophysiology. Did look at some of the changes between, say, the application of 5 a PEEP versus 15 a PEEP. When we're looking at that, when we look at this illustrated bit of a CT scan with a patient that may have ARDS, you can also look at the changes within that pulmonary capillary network. We start to look at the difference of our osmotic pressures. You remember that you got to have a good balance between those hydrostatic pressures and the oncotic pressures or the osmotic pressures. Uh, in order to prevent fluid from accumulating or for pulmonary edema to occur. And it certainly can do that. We talked about direct ARDS and indirect ARDS or primary, uh, where the lungs are involved as opposed to where if it's indirect ARDS, it's ultimately some caused by a non-pulmonary issue that can come about. We also talked about some of the changes that you might see within a radiograph for those patients as well. Um, And then we reviewed the concepts of some of those lung protective strategies that we might employ as well. So that's pretty much what we did in week 5. It's a lot of information and a little time to cover. You'll have your first exam next week, and then we'll go ahead and move forward with the next topic on the list. Thank you all for your time and attention. Have a good day.